Hi, everyone. I'm MITRE. I'm a health informaticist for MITRE, a little over 5 years now. I like to call myself an engineer because I have a background in electrical engineering, systems and software engineering, and then went into nursing, where I tied it together with a medical informatics graduate degree. My focus has been on healthcare interoperability, I would say, for the past at least 12 years now. Right now at MITRE, I am one of the, I guess, tech leads or tech SMEs for the Codex Fire Accelerator. And I'm one of the original contributors for the mCODE Fire Implementation Guide. And Mark Kramer is the chief architect for it, but going back to 2018, there was a handful of us that saw the evolution of mCODE from the beginning. I'm also a co-chair of the Clinical Genomics Working Group at HL7, and I led the FIRE to OMOP subgroup in the HL7 Odyssey partnership, where we wanted to further align the data that was represented in FIRE with one that is optimized for federated analytics in the research space. And I am supporting the GenomeX use case under Codex as well. So thank you all for being here. We're going to try and make this as hopefully fruitful for you in the hour and a half or so as possible. My understanding in this presentation, or the request for it, is that there is to have a good methodology approach, of a structured model, and I'd like to further extend that. I imagine that it would be implementation as well for cardiology. So, the notion of a minimum cardiology set of elements, and perhaps adopting what mCODE, or at least some of the best practices that mCODE has done in order to help enable that to happen. And that's the nature of this presentation. I'm going to put myself off video during this presentation, but I'll go on and off during the interaction section. All right, so can you see my screen, the slide? Okay, I'll assume yes.
Yeah, we can see it, May. We can see it. Thanks, May.
Okay, wonderful. Well, I guess it's an hour and a half. We're going to compress some things a little bit more, but again, I think what matters more is that you have takeaways of, how you can apply some of the methodology and some of the deep dive of the modeling decisions that we've made in mCODE to potentially your exercises and how you create an information model and potentially FIRE-IG for mCARD. So the agenda would be, I'm going to get into a little bit of development history. I'll shorten that up a little bit. Talk about this mCODE, I guess, modeling methodology, which I've been tinkering with probably since 2019, and it's had a little bit of evolution since, but it hasn't changed that much, and hopefully you can find it useful to you as well. Some brief case studies of parts of the modeling methodology that was adopted, say in GenomeX, actually cardiac hypertension, that some of you are have worked on, if not are familiar with at least, and then maybe CC Direct. Then we'll get into an mCODE deeper dive in terms of, as an example, how we dealt with demographics, medications. My understanding, we wanted a generalized model for that, as well as labs, and then maybe some application of oncology specific terms, and perhaps how you might be able to apply it, say, for domain specific things, namely, say, within cardiology. And then that would hopefully take us to the latter half, where perhaps we can make it a little bit more interactive, talk about, some of the maybe specific needs that after I talk about mCODE you haven't really, considered, or there's something that might be a little different as it relates to mCARD. My understanding is you have this interest in SHIELD as well. Maybe we can do some interactive discussion for that. And then have some takeaways. Again, one thing is to learn about mCODE, another thing is, well, what do I want to do with it? Or how can I use it? And having some actionable items or potentially, co-develop some next steps would be very helpful, and then we'll wrap up. So a little bit of mCODE development history. Again, I think the opportunity for like this formalized mCODE started somewhere around 2018, I think was a little bit more formalized. But for those who do not know what mCODE is, there was this need to identify a minimal and actionable data set of oncology data elements. It was meant to be standardized and computable. And, the simplest thing that came up, for one of the originators who asked for mCODE was to say that, to this day, I still do not have one EHR and another EHR being able to consistently represent cancer staging, which is so important for, diagnosis, treatment, and monitoring. Why can't I even have that? So, so why not have this little minimal step? It is really meant to be originally this incremental, I would say data journey, for a lack of a better term. So, as part of the standard health record, we would start with potentially oncology elements. And you'll see here that these elements were meant to cater to different stakeholders that included patients, providers, research, payers, vendors, meaning like EHR vendors, potentially analytics vendors, and government and regulatory. And without, just keep this in the back of your mind of what these 6 different categories are, because there is a process and a methodology that actually helped to determine even how these categories were decided, right? But just for now, you'll see that it's disease, treatment, outcome, patient, genomics, and assessment as of today. So again, this is kind of the timeline to tell you how it's evolved over the years. Again, we started in 2018. The important thing here is that there was a multidisciplinary community that was involved, and that is so important because, as you find, there could be a group of subject matter experts that start determining a core set of data elements that might mean, something that's useful for their use case. But by the same token, there really needs to be not just particular specialties, but subspecialties, and this notion of informaticians that help to provide some kind of standardized representation, understanding of data models, and other types of groups that could be software developers. And in this case, there were researchers that were involved as well. And you'll see this journey that took us there went through from the initial release in 2019 all the way until now, with 3 standards for trial use, the most recent one, which was released on October 26th of this year. Okay, so I'm not going to do the deep dive into this at this point, because I think the process of how we got here is probably more relevant to the purpose here in mCARD. But just to say that at this time, you'll see that we have created a concept diagram that has these 6 different categories that I mentioned in a previous slide. And we thought about it in terms of making this useful, this concept diagram useful to not only say, technical mindsets of developers that think about data models, but more in terms of, is it also useful for clinical subject matter experts so that they can see, oh, I get it, as an example that, a cancer patient would have the notion of a disease and primary cancer conditions, etc. I'll touch more upon why it's so important early on to have a concept diagram like this, as opposed to the bag of words or the bag of terms that one might find, say, in other models where they're just simply lists of elements that might be relevant. But keep in mind that this is what mCODE ends up looking like right now. There's again, when you think about how we got here to this particular slide, there really is I would say when we first started this for this do one release, we didn't come up with the methodology all the way, like from the very beginning before you took the first step. I'm going to say a little bit that in some ways, we were kind of working through the notion that we needed a use case, but as we started going through the process, we iteratively started, identifying a methodology that we ended up, solidifying by the time we released this standard for trial use version 1. But, there ends up being one by the time it was first released, and this is the one I'm going to kind of present to you today. I actually presented this back in 2019 at a FHIR Dev Days conference. I still see or notice that this picture is still being used, which is a good thing because it kind of shows that, some assumptions of a methodology and how one creates the notion of I've got something in my clinical mindset. I have a need, to standardize data or for a particular reason. And really, there is this notion of a magic hand waving. If you don't have this kind of, formalized methodology or, somewhat formalized methodology, it seems to be this black box of suddenly you've got all these clinicians on the left side that will work together to define this use case. They might even have a certain list of elements. And something happens where they're kind of out of the picture, and then software developers and some clinical informaticians step in. They work on this in a little bit of a silo, and then suddenly there's this magic implementation guide, and it ends up being sometimes a little bit of a gamble as to whether the implementation guide actually reflects the clinical mindset that first drove the use case. And that was the motivation of, in some ways, why we wanted mCODE to have a little bit more of a standardized approach, or at least some heuristic or set of guidelines for doing this that we might be able to apply to other domains. It includes the notion of defining, the use case, the purpose drivers, use case scenarios, persona. These are probably things that you might think, okay, well, we've obviously done that. But when you start getting into the artifacts, when you're looking at gathering the relevant clinical information, then it starts becoming a little bit more of the, oh, okay, well, we've kind of missed certain things about it, which might include, not just the clinical information inventory, but how do they all fit together? What is that notion of the mind map, the clinical mind map that one has as they're figuring out the information that's important to them? And then how does that end up translating to a notion of a logical model? As much as I do, like FHIR and I'm a proponent of it, I've seen, that models are, there are many models that are out there, and in some respects, all models are wrong, but some are useful. And, if you have the notion of a logical model, it's very possible then that you might be able to reuse it for other situations or other purposes, say things that are research oriented, using something like the OMOP common data model and so forth. But that's where this becomes now a little bit more of something unique and a kind of a nice little, approach where, what one ends up, creating could be a little bit more resilient to changes in models, even as FHIR evolves, because as FHIR is a great framework, you're going to find that over releases, it can transform in great ways as well. So after that, we're going to translate whatever we have in our mindset to this notion of data elements, and potentially at that point, you're going to choose what I kind of call a reference model. And, for this case, it's going to be FHIR and their particular tooling. So as you do this Rosetta Stone, you'll end up creating the data dictionary to develop the FHIR IG. We're not going to get into tooling here, but there's one of the really nice things about the FHIR framework is that it provides wonderful tooling that allows you to develop these implementation guides in a computable way and allows, someone who is potentially, a clinical informaticist to hand this over to a software developer or integrator and say, hey, here is kind of the, the guide that I want you to use as you're going to go ahead and create applications or potentially servers to serve this information. I want to validate it as we go through it. Now, notice these are actually going, in cycles, because it could very well be that, don't think of it as a simple waterfall. It could be that as you're going through this, you're going to find that there might be changes that you might need, not just to your implementation guide, but to certain aspects of FHIR, because FHIR, like any other model, is also evolving. And as a result, the validation of this implementation guide could be in the form of examples, or creating specific examples that are in FHIR or your model of choice, and then a reference implementation. And once we end up going ahead and going through this piece, then you have this notion of, let's go ahead and have this in early pilots, or what I love to promote is the notion of connectathons. I've done many connectathons at this point as a participant and even as a lead, and I cannot stress as much how valuable connectathons are to help inform whether your assumptions that you've made first in a clinical mindset actually make sense and actually pulled through for the reason why you want to use it. Okay. So we're going to kind of take a little bit of each of these cases, each of these steps. Again, and some of these are high level, but we're going to try and apply it to see how mCODE actually works through it. For example, what's the driving need for the model? You're going to find in different cases, some of them is for clinical workflow improvement. That might be the case here. In other cases, it is regulatory. As an example, although it's not necessarily in, mCODE, there are certain types of, promoting, interoperability regulations. Say like the interoperability rule might actually help to inform why someone is, going ahead and creating a FHIR implementation guide on top of that. It could be many other reasons for that, but what's driving the need? Who are the target actors? And this was very important for actually mCODE in the beginning, because, while they could be patients, physicians, nurses, researchers, payers, we have this picture of mCODE that had everything that was, all of these stakeholders. But realistically, when mCODE was first created, for the most part, it was the dialogue among physicians and patients. And then it expanded over time. But this is important because the actors and the use case help one to scope and to prioritize what is relevant. Because otherwise it gets very easy to get lost in this whole sea of elements and not, sure what is most relevant to you. And you might end up using something like, a Delphi model, for surveying, but unless you have something to scope it, it still would be a very challenging task. And these use case scenarios, again, to maintain the clinical mindset in what drives these implementation guides, we really made this push that these use case scenarios be written in as much plain text as possible from the primary stakeholders who are helping to drive the business use case for that's resulting in an implementation guide. And we kind of said, well, write your scenario in plain text, but really create your example persona as deep as possible. And then if possible, cite the clinical sources where you got it, where applicable. So this is what happened in 2018, and it still happens in other implementation guides that I've been working on. So in some ways, it's not unique to mCODE, but the approach and how we actually determine the elements was pretty good in showing this here. We had drivers in mCODE where we needed a common representation of minimal and actionable set of cancer elements. You can replace that with cardiology, say in your case. But there were two cases, and this you'll see on the right was written by the multidisciplinary team that drove mCODE. I think, ASCO at the time was facilitating the creation of these clinical use cases. And you'll see that the first one, back from 2018 was a, renal carcinoma, renal cell carcinoma. And you'll see the description and clinical text here. And then beneath it, there was a second use case where one of the subject matter experts stated that, cancer, at least the direction of diagnosis, treatment, and monitoring of cancer is highly dependent upon genomics, large-scale gene panels and next generation sequencing, which merited as a result another dedicated use case scenario for next gen sequencing, and that's what you see here. A little bit of a teaser of how then we ended up doing, some of the element identifications is that you'll see that myself and Mark and other folks like Ruth Martins Baptista, as we were accepting this from clinical subject matter experts, the clinical informaticians and modelers were absorbing this and extracting from it different domains based on keywords here. So as an example, you'll see, they said JS is a 68-year-old Black male. I'm just putting a couple of them. It wasn't exhaustive because there's not an analysis of a use case, but you'll see we highlighted, okay, so this is the notion of a need for a patient and the notion for race and, comorbid conditions and a provider. And, as we went through this, it now ended up, again, starting to get into the mental model of the subject matter experts that had the driving need in order to start the collection of certain elements. Again, one can look at every possible scenario, every possible paper, with regards to what elements might be relevant, but unless you give it context, it will make it very challenging to manage. And that's what we ended up doing here for both use case scenarios. What we recommend in that next case in the methodology is, at this point, what kinds of resources would you potentially need? And I contend that at this point, you would need subject matter experts, and I highlighted this, an objective facilitator. It's so critical to do that because the notion of bias definitely plays into something like this, where want to make sure that every major stakeholder weighs in, and not necessarily that the loudest voice is the one that actually gets it, but one that helps to weigh in, how one can navigate. Again, going back to the original use case, did we cover everything? Are there certain, perspectives in the use case that we were kind of missing? But doing this really does need an objective facilitator. Again, maybe it's my own clinical background, but I cannot stress too that we really have to encourage subject matter experts to use their own speak. In many cases, what we found before, not necessarily in mCODE, you tried to avoid as much as possible, but oftentimes it would go from, hey, I have a business use case. What does this mean in fire? And I think that's, in some respects, that's a little bit of a trap, because in some cases, fire, has the rationale for certain designs in fire were very technically oriented, and it's a little bit easy, or the tendency might be that we start losing the reason why folks are doing this, and suddenly starting to make it a technical solution where it starts to drift away from the original need, or because ultimately it's about satisfying the clinical or business use case. At that point, you might, and a computer might ask as an example, how important is, let's say, blood pressure, right, to you? And, you might have certain, certain subject matter experts saying, oh, it's extremely important. And then you might end up asking, well, how many do you take a day? Can you give me an example in your own speak of what you would end up doing? As you further delve deep into your use case scenario, and then they'll give you some examples within their own speak. This is the thing you want to capture, because informaticians at that point will do very much like what we had done with mCODE, which is to start piecing apart the intent of, what a potential, what it clinically meant, in a way for us to represent it using the right resource. And again, exploring prior art, that's very important in that sometimes it is the only thing that you're doing. You may have a particular use case where the specific focus is to represent a pathology synoptic report. But in the case where it's not, and you're kind of in a new domain that really hasn't been explored before, exploring what others have done ends up being very good to give it further context. Again, conceptual models at this point is really relevant here because they establish the relationships. We had explored all of these, actually, when we first started mCODE. We used FreeMind and XMind. The very first version of mCODE actually used a software called Coggle. And right now we're using this open source public software called Draw.io to create SVG files. And oftentimes we do lots of plain old whiteboarding. The process of going through this is so relevant because as you start doing this, it starts giving meaning, context, use for all of those elements that you're thinking about. Okay, so you might have a list of classes and elements, but again, as soon as you apply a use case to it, you might find that certain things are missing. So there's a notion of a logical model, a conceptual model. I'm not going to get too much into that because I think that starts getting a little too techy for our scope here, but I'm happy to explore that afterwards. But the notion of going from a conceptual model to a logical model is very helpful after subject matter experts buy into this, basically, high level diagram of what certain things mean to them. So if I were to choose, like, say, for mCODE, let's go back to this. I'll show you the picture of mCODE. If I show you this for the picture of mCODE, this is very much, I think, intended to be the middle ground between something that a clinician can understand, as well as something that an informatician can understand. If it's not something a clinician understands, then we've missed the mark. But I don't think that was the intent. It's one of the reasons I think why there's a lot of, I think there's been a lot of compliments about how the mCODE implementation guide was written. And I believe this is one of the reasons why, because it does bridge that mindset. Now you want to create a data dictionary. So, which is, how do these logical elements map to the thing that we're trying, the eventual model that we want to get to. So what did we do? We did this clinical information survey. Again, we wanted to tie in the use case and the steps behind the use case so that we can further break down how data elements are used at what point in the workflow. Obviously, we can't get to every one of them, right? But what it does is that it helps to give clinicians an idea of, as you prioritize certain things, the clinician ends up asking, is it really relevant for me at this point in time? Because at that point, if you have an implementation, where you're kind of scoping back because for whatever reason, whether costs or whatever, you cannot implement all of it, then it really helps one to understand from all this bag of terms and elements, which ones, did I think I wanted to be important, but actually it turns out is not as important. So let's step through some of this. I'm going to put this away for a little bit. This was an early example of the process that we went through in order to determine the mCODE elements. And I still think it's true because you're going to see similar types of spreadsheets that have been used even as recent as GenomeX in the past month, which is we start with the notion of what that write-up for the use case was, right? Let's say in this case, it would have been the renal cell carcinoma use case. Let's see if I can bring that up. Okay, so the renal carcinoma use case at that point ended up talking about the seeing of a patient, the doing the workup and the assessment, and then the diagnosis at that point. And that's what you're going to see here as we started taking certain highlights in light of the use case description. We started putting or determining, and we meaning informaticians ended up looking at breaking apart categories of phases of a workflow, such as the initial assessment, what kinds of things would happen in between, the diagnosis piece. And then from the highlighted words here, we started writing in what kind of information is needed based on keywords. So age of diagnosis. Notice we have not gone to FHIR yet at this point. We've just basically said, these are words that a clinician should be able to understand. We asked, hey, are these good examples that we can use? And they would say yes.
May, can you bag it any more than that? Can you, it's still a little hard to read.
Oh yeah, no worries. Yeah.
There we go, thank you.
Yeah, no, appreciate it. Okay, so then we asked examples, which is very important because it now gives, again, this is still clinical speak, but it gives ideas, and you're going to find that as you work through this, you're going to find, wow, the name of the element that I thought it could be turns out that based on the examples is probably not the name of the element. So, you know, one could spend a long time talking about, you know, definitions and descriptions, but until you actually place examples behind it, you know, we're kind of, I guess, assuming in our head what we think it could be, and we'll find out that it might not be. Again, we've run into this in GenomeX, this happened in mCODE several times and so forth. We talk about where this information could be retrieved. And then there was a use case that was kind of brought, which is this notion of, a patients like mine use case that helped to frame some of the reasons why you might do this. All right, so, and we did this as well here. Okay, so we did this with renal cell. We did this with next, oops, sorry, I'm going to put this out. We did this with next-gen sequencing. And then once we did this first pass, it was given back to the clinicians. And I believe there was someone at ASCO who decided to survey the subject matter experts to decide how important is it to them, and is there something that, you know, was not understandable and so forth. So from this survey, it was handed out to several folks, and they were asked, well, how important is it to you at this point in time? And it was given to 5 different subject matter experts. Some of them based on the name I know as an oncologist, a couple of oncologists and so forth. They gave their rating, and then just to close this out again, we basically summarized it back and then added this tiered system where, depending upon whether it's, you know, somewhere in the range of 1, 2, and 3, it kind of filtered out the, you know, the priority in kind of an estimated way. And again, this is just to start, right? So you'll see that that's what happened, you know, and surprisingly, from the use case, you know, there were certain, you know, it turns out that, say in the initial assessment, these high-level discussions like, oh, well, we want to see this information called signs. And these signs would be like, well, obesity, do you have a wheeze, etc. But then when they're going back to the use case and saying, well, do I really absolutely want to know this particular thing for the purpose of this patient's like mine application, their answer was, well, maybe not at this time, right? From the initial assessment. However, I think what happened is this would be the first time that we would go around. Once we showed this back to the community, they would kind of readjust, whether it was the story or whether it was, the element, but eventually this around. But this was very insightful to already start thinking about prioritization. All right, let me go back to my slides. All right, I'm going to pause here before I go to the next piece. Just a quick check. Is this useful? Are you finding this useful of what we're doing right now?
It's very useful.
Okay.
Really great, May. Thank you.
Okay. Wonderful.
Yeah, this is really helpful. Thank you.
All right. So, good. Okay, great. Then I'll keep moving forward. So once we did that, again, notice that we started with the scenario, something in clinical speak, but then that could be a whole bag of, disparate terms, and they may not necessarily be organized. We're not quite ready into the fire yet. We're now into the, we've got all these loose words like current medications, diagnostic imaging, tumor histology. If we were to group them, right, into, well, what does this kind of mean? Are there certain other things that in our use case we didn't further consider? For example, in the use case, there's like patient JS has this problem, but we know, and this is an informatics exercise for the resources, those are the ones who would work on this, they would probably know, well, based on what we know with existing models, this thing in white was what was explicitly stated that was needed, but we also know that in that use case, because it's in clinical speak, sometimes you might miss, the thoroughness that, a patient that has a problem, you probably want to know when they had the problem or if they have the problem still. And, as in another example, there was a list of medications a patient was taking, but, was probably not included was, hey, when did they start it? When did they stop it? What is the status of what they're doing? And so as we're doing this, we would start filling in this notion of a data dictionary. Again, still not going to fire because you might think about other models that might be more relevant. But we started going, well, regardless of the model, you still might need the following elements, and we would mark this as new. So yeah, the subject matter expert said this, we'll propose additional ones and then say, well, would you also consider things like this? What we also started doing is from those list of elements that were tied to that particular workflow that you see here, we're now beginning to organize them into these notions, and we call them domains, although that's such an overloaded term because they're clinical domains, et cetera, but say categories of clinical data that ends up saying, well, this is where you would probably want to do it. Okay. And then from here, we would say, well, is there some other list of related clinical information that we need to know about this? Again, as examples. We recognize that within the use case, there was, like, say, in the case of like breast cancer, you might have prognostic factors. Here are some examples, but we also know that at least our assumption from the start is that that could be in a category called cancer diagnosis. So we're starting to organize, not only translate them into, more tangible data elements. At this point, you might as well call them data elements, but we're also, trying to organize them by category. I guess in USCDI, you might want to call it a class. And say in fire, you might want to start calling them resources. Notice I don't call them fire resources. I don't do that because eventually you're going to start realizing that some of these would probably go into different fire resources. So, my recommendation is don't jump straight necessarily into fire, because unless you have something to ground yourself with, you don't know if the issue might be a limitation in fire or a limitation in how we're representing the data based on our needs. Okay. Again, if we were to just go through that list of terms, that this list of terms may not necessarily be able to let me know, say, I have a problem, but is there a patient related to this, right? If I have a medication, then is there a reason that I'm being given the medication, or I'm ordering the medication? And this is why you almost need to have very early on the notion of a conceptual modeling diagram. Because what it starts to do, and the huge benefits, not everyone does it. I guess it depends on, why you're doing this in the first place, but having conceptual modeling, especially if it's a new domain, is incredibly beneficial because it enables SMEs to more easily understand the context and use of the elements. Why would I want to use this? How do they relate to each other? You may find out at that point in looking at things visually that there may be additional information that's missing. So one could say, if I just said I have a need for cancer staging, at that point, you don't necessarily know unless you have this link of going, well, cancer has to be staged to a condition. You can switch it to cardiology and go, gee, heart failure staging has to be linked to a certain condition, or potentially one or more conditions. So, unless you do something like this, it kind of is hard to visualize it, right? And again, I kind of go back to the notion of, classes and elements underneath it. The groupings are important. So I see, as we started going through this previous slide of, let's start grouping them together. That helped to drive these color-coded things that you see here. Oh, well, instead of condition, we started calling it disease because we realized that there are other aspects to characterizing disease. And then, we realized too that as we had certain elements, we have to start linking them together, at least so that we can conceptualize it. So benefit is really huge. And I think I mentioned this before already. If I look at this, of course, if I just did not have this like picture coding saying this is a fire element and this is an extension, if I just looked at this without knowing this is fire, I can still make a lot of parallels of information of how it relates to each other that's important to me in my use case. So, in this case, I know that a cancer stage should be linked to a primary cancer condition. I have worked on other projects like with the OMOP Common Data Model, where if I didn't have this, doing a mapping from fire to OMOP would have been very difficult, right? Because you'll find out that even the foundational principles of some models, whether it's used for research or other uses, will have a very definitive reason why certain relationships might go to different elements. So having a starter, of how you want to use this in a visual way is incredibly important, at least helpful for me. Again, as a note, what you see in mCODE here is that the conceptual models are notional. They loosely represent the actual fire model. So, when you're going to see is when we do the mCODE walkthrough for the deep dive, it is a lot more, these are human readable element names, but how this is actually represented, medication, the reason, procedure, intent, looks very different in that you're not going to directly find always that link, to cancer-related medication requests. In the case of genomic variant, you may not find all of these directly related. They might be related like in a couple of layers underneath, but that is not the point of this necessarily. The point of this is that does this match our mental model? You know, do these make sense as we start, you know, looking into the FHIR representation, which gets a lot more technical at that point. This helps to ground you to go back. Okay. All right. Another reason why you want to use conceptual models is something that happens a lot, regardless of mCODE, which is that models, standards, they're constantly changing, right? As much as we want them to be, quote, normative, it still does change somewhat in terms of how you want to use them, or potentially some of the guidance behind it. There is this notion in FHIR called a maturity model. Let me show you an example of what that looks like. Where this is the FHIR spec. Let's put this away for a second here. And you'll see that in FHIR, if you think about these like Lego blocks, there are lots of individual things called resources that help to describe certain elements like patient. Right? These are all the things that I'd want in a patient. And these are all things that I'd want in a condition, which is like kind of the, condition, which is also known as a problem. But getting back to the maturity model, these things, these numbers here are maturity levels, which is how much has it been used? Is it something that I just conceived? Hey, here's a good idea. This makes sense to have a formulary item, but no one's really used it before. So we are letting you know, give it a try, trial use, give it a try and let us know. And there's some that at that point, and if you click here, you'll see all of the different maturity levels. At some point, when it gets used and it's almost ANSI equivalent, and you have it locked in that you're not really going to make any breaking changes, at that point it's going to be normative. And I'm showing this because, you know, as we have information elements that are needed, as we identify data elements that are needed, as we try and figure out the relationships among all these elements, you're going to realize that whether it's because of your own implementation guide, or whether it's because of FHIR even as a baseline, because the maturity model is, say, very early, that's not to say that when it goes to a next version, it may change drastically. Sometimes the reason or the context in which we created it also might change. And that's why it makes sense to have this so that you can keep track of, well, what did we think about this before? How do we see this now? Which of my implementers are still doing the one before? Which of my implementers are thinking about using the new one now? And the two examples I have here is, you know, if you see mCODE in version, let's see. And by the way, just kind of quickly, if you go to, you know, the build, this particular link in mCODE, I'll put it in the link or somebody else can do it, that'd be great. You'll see in this piece, and this is a nice thing about FHIR, is that every one of these implementation guides say, that's been published, check out our directory of published versions. So if you were to click on what we had in 2019, and if you click on what we have in 2023, such a nice thing that FHIR does, such good, you're going to see all these differences. You're able to do the differences in what is potentially changed between the resources. And this is what's happened. In STU1, as an example, comorbid conditions in Karnofsky were considered loosely part of a cancer patient. Oops. Right. So if you see here, this color, it was in this, again, this is a loose notional model. We thought about ECOG and Karnofsky as characterizing or attached to the patient. In STU3, because our, our focus, or our understanding is now that, well, ECOG and Karnofsky is really an assessment, right? Changes over time. Yes, it's performed on a patient, but it's an assessment. This has changed the context in some ways of, where, again, even though the FIRE model may look the same, regardless of 1 and 3, how one uses it or how one thinks about it as you're grouping things in classes and elements, it now changes it. So I'm going to, pick a little bit on ONC here. If you think about USCDI, right? ECOG and Karnofsky is considered an assessment, but if you kind of leaned on mCODE originally back from 2018 or 2019, one would have thought, okay, well, mCODE says this is part of a patient. So having this notion of conceptual model helps to give a context, even though ECOG and Karnofsky, in terms of its representation, has not changed since the very beginning. The same thing happens with tumor markers. In STU1, they were considered lab tests, and in STU3, they're actually more characterizations of disease. So we actually kind of thought about it differently. Prognostic factors now being a disease characterization and not just a lab test result. Again, going back to, really try and create conceptual models early. The next piece is that you want to validate your assumptions with examples. This has been invaluable to me because something we fought for early, when we first started mCODE. Examples helps to pressure test your assumptions. So if you think about our journey within mCODE, again, going back to this, we created our workflow elements, relationships, and we even made some kind of assumptions of FIRE examples, which we'll get to a deep dive. Then the next question is, well, if I had a persona in the beginning, just like patient JS, right, from the start, let me create this notion of that patient journey and let me see if the information that I need as I go through the entire journey has an equivalent element and a way for me to represent it in a way that is computable and maintains integrity and doesn't fail my validation and has, all the must supports and potentially required elements that's needed in order to have a structurally and semantically sound FIRE set of resources. And this, is, incredibly been a learning experience when we were doing this, because as we were figuring out, well, here are all the elements that we need, here's how they relate to each other, we started realizing that sometimes the model that you choose, in this case FIRE, will have further requirements, or potentially with mCODE further constraints that we impose that suddenly makes this potentially challenging. And it kind of required us at that point to think, well, gee, the example doesn't quite work if we're going to do this way. Do we need to change our profile? Do we need to change our customization? Are we missing an element that we need to have? And this is what happened as we were, I think, let me see if I remember this. We didn't add this until, let's say, yeah, we didn't add this until the second mCODE release. The first mCODE release is very much at that point a theoretical exercise, right? Where you're seeing this concept. If you notice here, there is no major examples that we were putting in here, except for the ones that were identifying how to use things like comorbid condition. Actually, we didn't even have it here before. But now you're going to see in STU2 and even STU3, we have this notion of this basic examples. So each one of our elements has examples that show what is it like to be a cancer patient, right? Here is how it looks like, so that you can hand it over to a software developer or implementer. And then not only do we have them specific to the, to our customization profile, here's where we had the extended example. We took our patient persona and, we provided the description of it, and we hyperlinked every one of the keywords that we had examples for. So, we said patient Jenny M is that 55-year-old Hispanic female. We highlight this one because the patient already has race, gender, past medical history, etc. We went through this notion of this patient journey over the years. We broke down, and this is kind of nice because as you're going through this would be your list of elements that you have determined are relevant for your domain. Say you would have a cardiology equivalent. You would have links to the profiles. And then knowing that not all of this is mCODE, some of these are, potentially pulling in from Firebase, which mCODE does allow, in order to create your persona. And the nice thing about Fire is when you do this using the tooling in Fire, you're able to have a validator identify whether something is broken, whether something passes, and so forth. Now you'll see in some of these that some of these are red, and these are actually, the reasons for these are tooling. It's not necessarily that we misrepresented it. Another reason why, as you go through this, have something that grounds you, because again, as much as Fire is really great, it's not perfect either, right? So have yourself a grounding. Okay. So case studies, wow, I have to really press forward. Again, how have others done it? And I want to bring this up because there's some folks here in Cardex. I got to admit this, I really liked what was done in Cardex. I kind of did, I kind of evaluated a little bit in light of some of the processes or methodologies that we have here. I think it's good in that it did identify, the use case and the scope. It provided a workflow, a persona, again, very similar to that patient journey that we did back in, 2020 when we did this. And it just kind of shows that this is a nice, application of it. There were data elements mapped to Fire resources, and, examples are included. And then, say in the final one, when you release for trial use, you want to pressure test it with connectathons involving the community if you can bring them in. And, while this is not complete yet, there is already planning for a January 2024 connectathon. So parts of these methodologies nicely applied. Here's another example, and again, it's not necessarily that things are wrong or right, especially in this situation. In some cases, it's very much an art as much as a science. But CC Direct, which is basically the initiative for pediatric oncology and the need for standardization for this, it's in the early stages. If I see in terms of the types of steps, there was there's several use cases defined, and I guess that's that's good, but it also makes it very difficult to scope in a short time frame. So I guess one thing I would say is that it's thorough, but probably needs to be further narrowed, at least, or prioritized. It's got a set of elements, like where they came from to, I think, is something that is still a work in progress. But the one thing I would probably say here, again, not good or bad, is I think the reason for it, what they've done here is, and the reason for it is potentially that they figured, well, how can mCODE improve to, address pediatric oncology? So for this particular use case, they decided to compare with existing Fire resources first. It probably wouldn't have been my approach to it, but if that's effective, then, or maybe the reason why they've done it is because they already have prior art, or they scoped it so that they just wanted mCODE. They decided next to prioritize the data after doing Fire mapping. My recommendation would have been to do it before, because if you find this whole list, this whole bucket list, and there could be hundreds of terms, and you want to find the Fire equivalent, and then you want to prioritize it, you're going to spend a lot of time here to realize that you're probably going to only want 30% of it. So And maybe that's worthwhile if you plan on using all of it eventually, but if time is not your friend, then I probably would have put it earlier. I would have also done the data flow requirements a little bit in parallel. Maybe it's just that this diagram is not necessarily, truly illustrative, but I would probably have done this in parallel. But that said, there are some really good things here in that I love that how they did the consensus base for the use cases in a very methodical way, and using again, I think they even did them by percentages and came up with certain consensus of what's important by certain types of criteria, whether it's impact on patients, impact on clinical care, et cetera. So that's a very good way that one could help identify prioritization. If one, however, thinks that they're trying to work in terms of increments and working on sorry, hold on a second. Yeah. I'm sorry. If they're working on perhaps trying to get to pilot very quickly and showing proof of concept or proof of implementation, then there could be other workflows that are more optimized. Finally, the third one, GenomeX data exchange. Again, I'm going to preface this as a disclaimer that I could be biased because this is another this is a use case that I'm working on and drove a lot of what's in here. So maybe I might be overselling it, but I'm also going to try and highlight the things that I could have done better, I guess. With GenomeX data exchange, I would say in less than, I would say since February of this year is when we really started doing some of this. In the beginning, is created a process flow. And our use case was very clear and simple in that we were trying to send structured genomic reports from a lab to an EHR. It was small as that. The implications, we narrowed it down to oncology, and then we immediately created a process flow of how we would curate this data, identify the information elements that were important to us, again, in clinical speak, right? So we had a combination of oncologists, lab, reference lab representatives who are project managers, genomics SMEs, and informaticians. We're all working together to identify, curate some test examples, identify in clinical speak what the information elements were. We provided descriptions. And then on top of that, we asked for prioritization. And prioritization right up front, meaning, is this important to you so that it's critical to make it minimal and actionable so that you can make a diagnosis or treatment decision behind it. So we narrowed our actors to the oncologist and to the reference lab representative who creates the interpretations for these reports. And so we said, is this important for you first? If not, then when would you like it to be important at some point, which means future phases? And that allowed us to then quickly go into short order to start getting targeted reports to identify the characteristics, and then we went through the information elements. We had, in looking at prior art, because it was oncology based, we already had an implementation guide that we were working off of. And on top of that, another one, which it was dependent on, which is called the Genomic Supporting Implementation Guide. This ended up informing this. For our initial first pass at this mapping, we went through one connectathon, again, probably 3 or 4 months later, which is pretty short order. And the results of that informed changes for a second pass of our mapping. And when we started doing more and more, constraints in how we were figuring out the use of these elements, we realized that we likely probably needed to have our own supplemental implementation guide. And that's a greater question too, they're going to need to have for mCARD. if you are thinking about multiple use cases where, you want something like mCODE that's clinically minimal and actionable, right, across all cancers, but you now have carved out particular types of abilities that pull from mCARD, then you might want to come into a situation where, okay, well, mCARD might be your broad scope, not necessarily the kitchen sink, but, loose enough so that you can start doing more targeted implementation guides. Maybe the hypertension one could have been underneath, and I'm not sure what your scope is for it. But at that point, you may come to that realization that could it be enough of a foundation so that you can start building supplemental guides on top of it. This is one example where it fit very nicely. Okay. All right. So that said, I know we're really going over, but I'm going to pause there before we get to the literally getting nitty gritty with mCODE. Did the methodology help that section? Just a quick check.
Yes,
Yeah.
Okay.
extremely helpful. Yes.
Yeah.
Right.
And May, I would just say too, it's so excellent. And I love the fact that it's grounded in informatics. So it makes it logical and intuitive. So I just thank you from everybody that's in the standards world for all the great work. Really, your team has done an amazing job. And thank you for sharing.
No, of course, my pleasure. And I have to admit that, I honestly really do stand on the shoulders of giants. Again, a lot of what I'm presenting here is not possible without Mark Kramer, who's not on this call. He's the chief architect of mCODE. There's so many others who've helped, develop and improve this methodology, like Caroline Pottiger did a great job on the, improving the methodology for gaining consensus in a measurable way, which we had not really thought about before. I mean, we did it, but it wasn't so, I guess, scientifically applied. So again, there's quite a number of folks. I'm just mentioning a couple. There's a whole list.
Yeah.
So.
Well, we're really appreciative.
Okay, so thank you. Let's keep pressing. Oh, go ahead.
This is Bruce. Yeah, very helpful look at that. I've been looking at your sort of the big diagram and how that needs to morph for cardiac things, or I guess thinking is more as an internist now. That everything that you're calling a comorbidity would fit on a problem list. So kind of expanding the problem list sort of thing. And then we have a lot of outcomes, of course, in cardiology that need to morph from the tumor-specific, kinds of things. So it'll be interesting to see how to, because I think of kind of the problem list is going to be a little more core to what we talked about, and then a bunch of each of those problems has various outcomes or functional status levels. So it'll be interesting to try to morph from there. And I guess we'll get into the details when we do a deeper dive through some examples. But down to like a terminology service that covers, we think solar is SNOMED, LOINC, RX norm kind of things. And we do rely on SNOMED in some of the hierarchies there, because as I said, heart failure has multiple specifications, just like cancer.
Yeah.
Figuring out how to navigate up and down some of those hierarchies is one of the key elements, and I haven't seen that as much here. So figuring out how to do that. And then of course we have lots of registry dictionaries and guideline content that really does define a bunch of our data elements, and we really try to translate that into something a little more structured to use. So there's a lot of commonalities and then some differences that we need to sort out. But this has been helpful to get us partway down that road. So thanks.
Yeah, I appreciate the feedback. And again, we definitely, I definitely am open for how we can improve and evolve, the work. Okay, and
This is Jimmy Chang. Do you mind if I ask a couple of, I think these should be short questions, but I do have some fill in the blank stuff here. So
in terms of defining the use cases, kind of step one, who actually authored the persona-based story?
That was a combination of I think oncologists that were part of the initial mCODE executive committee. So I would say Bob Miller from ASCO at the time, Travis Osterman. For the next-gen sequencing use case, it was Wendy Rubenstein who worked on that, and Monica Bertagnoli had a huge hand in the initial discussions and the need for the use case.
So
Not to name drop, but she really
good.
was involved in the beginning.
Yeah.
So.
It's really the clinicians who created it then, and it was based on assignment.
Yeah,
You need to do this type of thing. Second question.
That's correct.
What's the software tooling that you use to develop the conceptual models?
Oh, good question. So originally it was, well, it's a geeky question, but originally it was Coggle, but I wanted something that was public because that was proprietary, and we now use Draw.io for a lot of it.
Okay.
So it doesn't really matter. I think that's the brilliant thing about it. Although let me see if I can open it. Although we use Draw.io, let's see, where is it? This is.
That's all right. I was just wanting to replicate as much as possible. So what I'm conceptualizing here is if we could take your STU3 conceptual model and bring that in and then start filling in the blanks. I'm looking for ways to shortcut all the work that we have to do.
Yeah. So this is literally the file from the implementation guide. And we put it inside Draw.io. And what's nice about this is that the format is called an SVG file, which if you look at it it's literally code, but it can be imported in multiple tools. We like this one because it's free. And the way this has been organized is in a way that allows you to insert the URLs. Do you see this? This is the URL. And basically, when we export it and insert it within the IG, it now becomes a hyperlink. So if you look at the picture and you literally click on primary cancer condition, it takes you to the page.
Sweet. Okay.
And that's because of what we did here using this free tool.
Okay. In step 3, you create the Rosetta Stone. Is there an ontology or a value set for the variables used in your domain and your clinical information name columns? Or did you do that on the fly? Or is there a guidance, et cetera?
So so I had a slide I was going to talk about this, but it's funny that you mentioned ontology, because there's the notion of model of use versus model of meaning. And the world of ontologies definitely goes more towards this notion of model of meaning. And this might be a controversial statement, but I would say that FHIR is very much a model that leans more on structural elements, closer to the model of use. So, and mCODE is no different. So, as an example, you might have different models like maybe the mCODE to OMOP is the best way of doing this. You might have like a set of elements that are really high level. Like you might have just something that says problem. Okay, let me take an example here. Oh, I'm going to give you a slightly long answer for this, but I think hopefully it'll help if you're going to be working on this. Okay, so all conditions, right? It's possible at this point that condition will say you have a code that shows what the condition is, in which case it's condition problem diagnosis codes, right? And as you see this, it may be, at least for US Core, that it may say, oh, well, your condition problem is all the SNOMED codes ever in the world, right? And there's two ways that you can approach this, right? If you wanted to say, I just want cancer conditions, or I just want cardiology conditions. One, you can literally have an element name called cardiology condition, and then you have a value set of, just all your cardiology conditions in SNOMED. The other option is that you just say problem, and then you use an ontology, and the ontology will say, go to this particular, area, and, to this particular spot in the hierarchy, and that will be all of your cardiology conditions. You won't have an element name called cardiology condition. You would just have condition, and then the concept would end up telling you, oh, it's cardiology. And that one is very much the way a different model called the OMOP Common Data Model approaches things. They're very ontology heavy. So this long answer is to say that when we did mCODE mapping, and this is a notion I've seen in most most of the codex FireIGs that I've noticed, they start with the element, they identify the element, and then they put the value set around it. They don't necessarily think in terms of the semantic properties of the ontology first. That makes sense. So we start with the element names, we try and find the element equivalents, and then usually it's okay, well, here are problem codes. How do I further want to go ahead and, qualify problem codes? If that makes sense.
Okay, yeah, that helps. Yes.
So I noticed a lot of value sets to
Yeah.
do that, which
And-
is typical way of grouping.
Yeah, and there's other ways. Again, that's probably definitely a discussion for another time, and I'd love to have that discussion. But the notion of how one should better leverage a robust ontology and have a looser structural model, which leans more towards the model of meaning. I think that's something that could be further explored with some fire communities, but so far I found that that's not really the approach in the fire world. It's definitely more of the approach in the OMOP world, right? In the Odyssey OMOP world. But that's something we can have at another discussion another time. If that, please feel free to record that question. If you want to follow up later, I'm happy to do so.
It's particularly interesting for the phenotyping sorts of things that.
Oh,
Yeah.
so agree. That's the other thing too. If that's the one thing to go back to this, especially if your goal here is to use clinical data for research. And that's a discussion, and those are explorations that have really been coming to the forefront as we get closer to the, oh my God, buzzword, learning health system. The research side married with the clinical side and making it consistent, so you have to do so many mappings and disconnected concept maps and structural maps. I mean, that better alignment is really now coming to the forefront. It's one of the reasons why HL7 and Odyssey created the partnership now like a year and a half ago. And it's one that I think does not necessarily end with this discussion, but I definitely welcome it. So.
May, is there a chance that we could have a separate conversation? I don't know if everyone's interested or not, but around consent and research consent, and if there's any use of the two resources around research in mCODE.
Yeah,
It's a big loaded question, I recognize.
It is a loaded question, and so the question is, can we have it? I say, well, of course we can, especially, and I know that's something that is a concern in CC Direct. That's one of the aspects of it. So if we have that discussion, we'll probably bring other folks in because their lens is more on the consent piece. mCODE itself foundationally did not really explore or give, any emphasis on how to handle consent.
Right.
I would also say, though, that that's a more general issue, and that also happens with a lot of fire IGs as well. With clinical genomics,
Yeah.
they, as an example, they tend to push off consent to like a different kind of IG and a different work group dealing with consent, because oftentimes they tend to work on models, right? Information models. And I would honestly say that, and this is true for mCODE as well, is that when you work on cardiology, I would pay a lot of attention, not just to information models, but to the transport piece, in the how do you intend to make the connection? Because if your intent is in short order to eventually have a pilot, these are all going to come up. And it's something that we ended up doing and recognizing very early in GenomeX. And I think it's played to our benefit because it brought reference labs and EHRs to the table, because it's now working in the implementations that exist today for them.
And yeah, right. In cardiology, we had pushed that to other groups like I think Da Vinci and Vulcan are both paying attention to that, and we'd let somebody else solve it and then use it and focus on the clinical stuff that we have to do first.
Yeah, and that's okay. Again, I think that, whether it's this group that does it or whether it's a collaboration with another group, I guess the intent is that one, should make that connection pretty early. Especially if you're in a scenario where you want to pilot early. Anyway.
And
The CTSAs around the country are tackling this in the form of common IRBs and common consent things. So fortunately, someone else is doing it, and we can reap those fruits without having to cognitively load ourselves with that.
That is true. mCODE does kind of do that as well. We definitely do say, well, we use the analogy that we don't want the tail, right, to wag the dog. And in some cases, mCODE actually did that for a little bit, and you'll find it from the model in mCODE. Originally, I think in 0.9.1, we actually had a version where we were trying to model blood pressure, height, weight, CMP, and then we were like, okay, well, it's relevant for mCODE, and maybe at the time it wasn't solidified in other areas, so we were taking the initiative, and then we ended up, realizing afterwards that's not really a good use of our time. This is about our scope has to remain in cancer, but we have to recognize the importance of labs that help to identify, further qualify comorbidity states or prognostic factors. And then as a result, we literally backed out our profiles. And that's why you see here external profiles. But that's a good segue for me to get into this other piece, because it's important for you to know as you explore prior art and what you bring in that, yeah, it's nice to take pieces from mCODE, but you're going to realize too, in this particular scenario, that mCODE, if you don't have a profile for a certain type of data, but it happens to be available in FHIR elsewhere, you can bring it in because, and I'll give a reason in a subsequent slide, but mCODE has an open bundle. There's a constraint called open, which means if you're going to create an mCODE bundle, realistically, the only thing that you truly need to have in there is cancer patient. Other things are recommended as should. And then because it's open, you can basically stick in any other FHIR resource. Which may be from other implementation guides, like ideally. So, so as you look at things like, a cardiology, we might end up having a need for certain assessments, that exist elsewhere. Well, it's possible that you can create an mCARD bundle and then maybe make a should or bring in a dependency from another IG into yours, and it potentially expands the profiles that you can have, even though you have a core set of minimal cardiology elements. Okay, so yeah, let me keep. Yeah, if you can, those are good questions. If you can add that so I can keep pressing forward, I think that that would be. helpful, unless it's absolutely pressing. More than happy to entertain that as well. Okay. All right, so let me have this level set on mCODE as we do the deep dive. This actually came from the mCODE Stu 3. I just literally cut and pasted it here and highlighted the areas. mCODE, you're going to see as you dig deeper and deeper that you're going to find multiple ways to represent the same thing. And, you know, for folks that call mCODE like, you know, a tight data model, am I mCODE conformant, et cetera, there are certain constraints that we kind of put on there. There's certain things called invariants, which are certain conditions that you need to have a combination of elements that are in there. But it's not so tight that if you deviate a little bit, everything's going to fail. It really is not necessarily that way. Rather, the understanding of mCODE is now moved such that it really is recommending a set of patterns or templates of how you represent cancer data. Or in your case, if you want to take mCARD, the recommendation, at least as you start initially, is present yourself a set of patterns or templates. And one's going to say, well, then we're not achieving tight interoperability. But realistically, you could say, well, if you think about levels of interoperability, you're now at least identifying and, you know, grouping the elements that are most important to you for cardiology or for cancer, you know, and then as as your model matures, you can tighten it, you know, as more of the community begins to adopt, like, you know, the representation of these different types of elements. You know, once you get like a good sweet spot of adopters, then you can tighten. The other possibility is that, you know, folks feel so good about this that now it becomes a regulatory requirement, in which case everyone has to comply. Then you really have to tighten things up. But, you know, to start, if you are in a new domain that you've never really done one of these before, it might make sense to think about them in terms of patterns. That's the way mCODE is kind of right now. We have controlled terminologies. We have, you know, some that are required, some that are preferred, some that are extensible, which means that if it doesn't exist in your value set, you know, you can add it, but it has to be a unique concept that does not exist in your current value set. But that said, it's a set of patterns or templates. The second one I already talked about, you know, if you didn't have a profile, you could still include it because they're open bundles, they're open components. You know, you can potentially add it. Think about mCODE about, you know, the types of data that are relevant and interesting, but it's not exclusive so that if you put more things in there, it's not going to work. That's not the case. It's basically saying these are the relevant elements, you know, that if you're going to represent in FHIR for exchange, these are the ones, in some ways, it's more for the receiver. It's the things that the receiver, you know, should find relevant and should be able to find if you're going to be thinking about the world of cancer. Same thing you would apply for cardiology. But again, we've had lots of questions early on going, hey, you don't have diagnostic implications for genomic support, mCODE is broken. The answer is no, that's not necessarily the case because we can add it. You know, and we do have a dependency for a different IG in here anyway. So even though you don't see it in this conceptual diagram, yes, you can go ahead and add it. This third one is that you may find, I think I alluded to this before, that mCODE is foundational, right? Again, in some respects, the intent is that it should have applied, you know, to all cancers, not necessarily just one specific one. And ideally, it should, you know, even though our focus originally was an adult, you'll see that there's now some inclusion for things that were relevant for pediatric oncology, and some that were even added here, say for, you know, enhancing the oncology, you know, oncology model was kind of added here. But again, it was meant to be foundational. If you have some other IG where you like certain pieces of mCODE, but it's a specific use case built on mCODE, then you can have new profiles that can derive from mCODE. And I have some examples for each one of them in the next slides. This representation of patterns, this is actually inside the mCODE IG. If you're going to have a representation for a primary cancer condition, there's actually 3 ways that you can represent it. You can, depending upon what your requirement is. So let's say on the top here, say for maybe EHR, exchange, maybe this is what you might find in US CDI, right, for problems. I might say, okay, well, we recommend that you use SNOMED. Okay, well, in this case, the source data would probably want to populate a cancer using SNOMED code, in which case, if you think about what the profile, the mCODE profile for primary cancer condition might need to have, there are certain elements in mCODE that needs to be populated, not just the code, but other information as well, in order to appropriately, represent primary cancer condition. And they may be things like, it must support the histology, morphology, behavior. What would I do to put that? What would I put for body site? And so forth. This is the piece of the what I call pre-coordinated, post-coordinated situation. I know a couple of you probably know that dilemma. And this was mCODE's way of saying, here's how to handle pre and post coordinated variations and for what purpose. The bottom two here, the second one is probably used more for billing. So it could very well be that, that for billing purposes, you might need to include ICD-10-CM. But if that was your source data, then how would you populate the following fields inside the FHIR resource? Our recommendation is for this pattern, you would probably omit the histology morphology because it's likely that you're not going to have it for ICD-10 and the body site might be optional. The bottom one is probably more appropriate, for research or registry reporting. Again, because mCODE tries to cater to everybody, we have to be conditional on our patterns that depending who you are, you might need to use one. This bottom one would probably be, say, for NACER, or sending this to a cancer registry, like, and you might need ICD-03, in which case, what would you end up doing here? We would have this generic, well, this is neoplastic disease, and we have to fill that field in, again, because the constraints in FHIR, this is required. But because we made this bound to, if you look at the value set, we made this bound to SNOMED. You'll see all these SNOMED codes here and ICD-10. There is no ICD-03 necessarily. Like if you're going to use ICD-03, then you would make this generic because you have to fill something in. There's no ICD-03 equivalent for that code. Use histology, morphology to use the two parts of ICD-03 to populate it, where this would be the body site for the ICD-03 topology, and the morphology will be within this element. Again, these are bindings. This is, again, the notion that we have used, structural data to identify what we need first and then backfilled in the code itself. Right. Yeah, conversation for another time, but OMOP does this just the opposite. They'll just say, you have a condition and, there's an ontology code that would say, breast cancer carcinoma. It would be all one code, or just populate code, and then you would use the ontology to break it apart. And that's not the way mCODE works, or in many cases, FHIR doesn't work that way either. Just for the way they handle vocabulary. So again, the second scenario is other FHIR content can be added to mCODE. Again, I kind of alluded to this before. This is the profile in mCODE for the bundle. It says here, unordered open type by resource, which means that you basically have all these mCODE profiles underneath this bundle. And think of a bundle like a collection of things. There's a FHIR resource that just says the things that are relevant, that I'm going to stick in a bundle, put them all together and send it out to you all in one, is kind of what this FHIR resource is. And in this one, it is, what are all the things that I would include, and I could send at once that says this is an mCODE patient and the things about that patient at the time. It basically says here that you can add all the mCODE, resources in there, but you can add more things because it's open. And that allowed us to do this, which is currently in our latest mCODE release. It allows you to create an mCODE patient bundle where some of these are specifically inside that mCODE diagram, the conceptual diagram, I won't show it again, like primary cancer condition, the patient, it allows us to put in profiles that were called out in mCODE, but actually came from a different IG. In this case, the genomic supporting IG. It allowed us, because it's open, to include FHIR resources of FHIR profiles, which are not called out in mCODE, but are indirectly supported in mCODE because it brought in this other implementation guide as a dependency, and these would be the 3 that you have in dark green. And then there's some that mCODE just basically says in their IG, just through narrative, hey, you can include this stuff, but there's no constraints or rule sets checking for it. And that would be, as an example, this blood pressure, height, and weight, and other, assessments that you could potentially add in there. Sorry, we really went over. I want to do a quick stop here. I can keep going if folks want to, or if you have something else on the agenda.
Yeah, we knew that there were going to be people that had to drop at
Okay.
top of the hour, but we're still good to keep going. We're just trying to soak everything in that you have to offer. So
yeah,
Okay.
I think everyone in the next meeting is in this meeting.
yeah.
So,
Okay. All right. Well, I'll keep going, and feel free to interrupt me if you want to stop. Okay, so this third one is the profiles can derive from mCODE. Again, as you do your own whiteboarding, one thing is to boil the ocean. Another thing is to start thinking in terms of if I have a lot of use cases, maybe that's CC Direct one that I showed you originally, right? If I have a lot of use cases, do you want to create all these individual IGs in silo? Or is there something that's common to all of them that you want to create something foundational first and then start creating, either new IGs or potentially new profiles that are outside of your foundational IG that you can start, building off of. And, mCODE kind of took this tack. I've actually seen this as well in DaVinci, actually, the DaVinci Accelerator, where they have an IG called HREX. And there are other DaVinci IGs that, and HREX is basically, very foundational elements. Let's see if I can find it. They're very foundational elements that others end up pulling from, right? So it's just generally a health record exchange, and then you're going to have other ones like provider, data exchange, prior authorization, and some pieces will be pulled and derived from this particular IG. Same thing kind of happens with mCODE. As a foundational IG, there are others within the codex use case, like codex radiation therapy, which realize that there's so much depth to radiation oncology that there's no way you're going to stick all of that in mCODE. It's just way past the scope. So they have a, quote, supplemental IG that derives from the very high level radiotherapy course summary that's shown in mCODE. And that's kind of what I'm showing in this diagram here. So the takeaway is that again, you don't want to box yourself into a corner. You don't want to do paralysis analysis and stick everything all in one, right? And you don't want to necessarily box yourself into a corner because you need to do a fast turnaround. It's got to be somewhere, some middle ground. But if you think about it in terms of systems, right? And work streams, like you might have a group that's just dedicated to hypertension, and it might be that mCARD had some notion of hypertension, but not to the degree that the Cardex hypertension IG has. Well, maybe, at that point, you could have some of the foundational stuff inside, an mCARD IG, and then have, just at least the first notion of blood pressure, going into, mCARD and deriving from it. I'm just giving a situational thing. I know the Cardex IG is already out, and in process, but if you were to think of other areas, heart failure or, some other, maybe pharmacogenomics for, cardiology, maybe, at some point you might want to be thinking about, well, if we're going to be repeating you know, a certain percentage of common elements that regardless of, you know, what that specialty is, we're going to need it, then start thinking already in terms of what's foundational and already start thinking about other supplemental profiles or IGs. Okay. All right. So for those that are still somewhat new to FIRE and this notion of derivation, some people think, oh, is it like, you know, if you have a engineering background or software background, it's like, oh, is it like inheritance, right? Object-oriented programming and inheritance. And, you know, the answer is not quite, but the notion of derivation does have that look and feel of it. You know, I'm showing this because there is this, as I alluded to before, sometimes this misconception that mCODE is only, you know, is done just in a vacuum, right? That almost like if someone creates a database and, you know, a schema for a database, everything that you see here is just closed world. And that's not the way it works in FIRE, and that's the way it probably wouldn't work necessarily with cardiology. Rather, what you might want to start thinking of is when you first start, you know, try and, you know, see this as FIRE is a framework, and that framework has customizations, you know, customizations based on these starter Lego blocks. And these customizations might be by country, it might be by domain or something along those lines. And as you're creating your own on top of it, and you look at quote prior art, think about your assumptions at the start. Is it that, you know, like say in the case of mCODE, the majority, actually almost, yeah, just about all of the, you know, folks who are involved that were driving the use case were all based in the US. And the systems that were involved were EHRs that were kind of aligning to regulatory-driven certification criteria. You know, that was drawn, say, like 21st Century Cures Act and the interoperability rule that had the notion of a support for an API, and they're figuring what would be US core for FIRE. So this, in some ways, ended up being our shimmy in between because it was driven by our stakeholders. So mCODE, you know, is very much a US core driven thing. But if you see how this works, it's that the mCODE, as an example, let's take patients, a quick, you know, simplest example. Cancer patient not being driven in a vacuum was almost was determined with the notion of we need a cancer patient. We know that we are bound in the US for now. And we cannot just create our own base FIRE resources, because one of the cardinal things in FIRE is when you create a profile, you can't just create your own core resources. You have to use one of the ones that you know that are part of the foundational FIRE, and then you further refine. So if you see, you know, mCODE primary cancer, it basically is a FIRE condition that went through US core, which further can be the way I can do it. Let me do this back here. I'll stick this inside here. This is the mCODE profile. If we start from the picture, we'll do a little walkthrough. If you click on here, that's what gets you to primary cancer condition. That would be this picture. Right? And you see that we had a need for something that's unique to cancer. You'll see that this is derived from, you see this in differential table, and the way you read this is, if you see a profile, when you see a differential table, it basically says, we have taken it from some other, either profile or base resource, and we have further customized it with the following constraints. We made this a must support. We added this particular value set. You can only use this value set, etc. And we derived from, and this is all hyperlinkable, we derived from US core condition problems. So, and their differential from the base was all of this information. So if you see how this works, mCODE is constraints upon other constraints that were added because of US core. And US core pulled from the FHIR. This is all hyperlinkable. US core built off of this base FHIR condition resource. Right? And if you think about this as a modeler, right? See this as a Venn diagram, right? I have a need for cardiology, think about it that way, a need for cardiology, and I see that FHIR at the base has this, you know, the way you think about it is you look through all the resources, what might match for what I think about, and then you say, well, this scope, this is why boundaries and relationships are so important to read as well. This scope is basically about all of these signs and symptoms and concerns, but it is about all possible conditions that are out there, healthcare conditions. It's not enough. And basically what they're saying too is that it's optional. There's very little requirements here other than the patient. So how do we get to further narrow that down, right? And how do we deal with our own constraints that we had from the start when we first created our you know, scope and our business and our drivers, again, going back to the methodology? Well, we know already at this point that, you know, for mCODE, when you, or mCARD, when you choose it, you know, decide where your starting points of constraints are. But that said, mCODE basically is built off of US core, which is built off the FHIR resource. And you know, and it's either further extensions where you add certain elements, or it would be further constraints where you say this code can only have the following, you know, this element for code can only have, you know, certain kinds of conditions. In mCODE's case, certain conditions that are relevant to cancer. In the case of mCARD, certain conditions that are relevant to cardiology. And that's what happens here. In some cases, mCODE now actually derives from US core, and it also pulls from the genomic supporting IG because, again, going back to the methodology, we had a use case for next-gen sequencing. All right. All right. I was asked, I think, by Melissa, I think 3 areas of focus, you know, demographics, medications, and labs, I think. I think I kind of explained this just now in some respects, that this further shows this, that if you look at the picture, again, going back to our conceptual diagram as the frame of reference, right? What are we thinking about when we see cancer patients? You know, and considering our regulatory requirements, you'll see that mCODE uses US core, which if you see for patient, has many things about it. Let me do the walkthrough with you. So this. Do this. So let's start from the beginning. This is where the picture is, right? This is your base resource. Again, this is all possible patients. And if you think about the elements that are inside here, this is like bag of terms, right? Bag of terms for a patient has identifier, whether their record is active, their name, the long, you know, story here, right? Deceased, nothing, almost everything is optional. Actually, I can say nothing, but almost everything is optional, right? As you look towards this, you probably want to further constrain, well, I don't want all of this. I want to be a little bit more prescriptive. And the methodology would probably say, as you find your most important elements that are useful to you, these are the ones that you want to have as must support. And there are settings inside the tooling for you to have a must support configuration. So that way, when you have all of this loosey-goosey set of elements, you're now able to further constrain the things that you need and say, okay, from, you know, all of these ones, let's further narrow it down. And that's where we get to the piece of the mCODE side, let's go to cancer patient. And that's what mCODE ends up doing through US Core. So let's go through this. Say for mCODE, we need to have a name, contact information, birth date, blah, blah, blah. What you find is that in US Core, from that loosey-goosey, high-level set of elements, most of the ones that are already tagged as must support are already in US Core. That's what this S is. It is must support. And must support is really something in some respects more for the receiver than it is for the sender, which means that, if you see this here, it should be processed in some way, right? And there's your coverage. So you come up with your set of elements, you make sure that you have a good logical model. You use this conceptual diagram to help then use as your guide to how to further constrain, whether it's must support, whether it's making it required, or so forth, or whether the value set needs to be further constrained. You start, then checking at that point what it means in terms of fire. And as you do that, you're going to find out too that there may be other elements that are needed because they're out of what you expected that are needed, in order to send one of these fire resources. At that point, you're going to call it out as a gap, and then you're trying to work through, with informaticians to figure out, how you can, further specify it, whether you need to go to a working group, whether something is a bug and the working group needs to fix it, or so forth. So that's what happened with mCODE. And mCODE's current list, this is how you read it. This is the differential. This is what mCODE did in order to further refine the things that US Core did not cover. US Core did this to further refine the really loosey-goosiness that's currently in the patient resource. And that's what it ends up looking like here. If I look at the mCODE cancer patient profile, I look at the snapshot table. And this is the things that are in S, and the things that say 1-to-1 are potentially required fields, required or must support. So the way to read this is an example. If I see this is my element, let me look at when the birth sex is must support as much as we call birth sex out that's needed to identify for cancer patients useful for a use case.
So May, this is Bruce, we've been pushed to use international rather than US Core for starting with this because we do have some international implementers. Have you run into any issues, any core issues, so to speak, with US Core, with any international use of this?
Yeah, that's a really good question, and it's a really long-winded answer because, again, as you know, with international patient summary, there are certain sensitivities, that are in the universal realm, that for privacy reasons they prefer not to have, right? So the classic one is race and ethnicity. So that's one thing to be thinking about. So if you have in your use case, as an example, things that really need to lock that down, then you probably want to be building more profiles off of the IPS. The other thing too is that I think the IPS works from vocabulary off of a universal variation of SNOMED, right? Because SNOMED's membership is based on country, right? And not all countries have a SNOMED membership. So there's only a subset that you're going to get from the SNOMED International or even the SNOMED US, right, version that's maintained by NLM. So
that's an issue as well, but it seems like so far people are thinking that we can get by with that. There'll be obviously some tweaking, but there is a push for most new projects to be more international, with the right compromises as needed.
Well, and most of the IPS based on US CDI,
Right.
to start, right? Yeah, medications is the.
Yeah. And
So-
yeah, medications is a big problem, right?
We do
Yeah.
have some international interest and actually being pushed in all the accelerators to think that way and not quite so narrowly American.
Yeah, that's a really good point. I will also share that since mCODE has been published in at least a couple incarnations, there has been a growing call to create an mCODE international or UV version. We have done preliminary analysis of what is needed for mCODE to do that, and technically and informatically, it really is doable. The greater question is one of governance. But I would say that if mCODE did have a version like that, I would probably look to the IPS-IG as well as a good way to also be aligned with the rest of the community.
I didn't want, that doesn't have to be a big topic here, but that is relevant.
Yeah, right. So, I mean, clearly in this case, you would end up having IPS, right, put in here instead. Right. So,
for us clinicians, it probably doesn't matter as much as the insurers and bill payers and administrators. So.
yeah. Yeah, no, that's true. But again, I would kind of harken back to the very first slide that I shared on the methodology. That sometimes as you start getting deeper into the use of terminologies, context is oftentimes lost in it, especially in some vocabularies like SNOMED, because SNOMED doesn't have consistently definitions. It assumes that the name of the fully specified name of the SNOMED concept is sufficient. And like others may disagree, but I don't think that's true. I don't think the fully specified name is enough to do it. And
so that's part of our work is the definitions for what we do. And in fact, it started with that in our joint committee in the past. And there's some messiness there too, but yeah, just making it definable so that it's internationally understandable is kind of at least a side effort, if not a core thing.
Yeah, and I would say, again, this is not resolvable by mCODE. I mean, a number of things we're talking about here is not necessarily an mCODE issue. I think it's more of an interoperability informatics issue, right? How you gain consensus, and this is very true for the regulatory aspects. I don't want to make this a discussion review about US CDI, but I think it presents some of the challenges, right? In that the definitions are very helpful. But then when you start seeing the context of how they're being used, going back to the methodology, right, where if I showed one of the previous, slides of the examples, you see that, potentially showing in US CDI where some of these elements that you might think is okay would have an example that might say yes or no, right? It might say like, risk factor or staging or something along those lines, and just, kind of shooting off the cuff is saying yes, no. And that ends up being a red flag because, if one literally interprets that, then the element name or how you model it is going to be different. Right.
The examples are helpful to give you the context. I agree.
That's right. And it's definitely, if you had some takeaways on this, yeah, for sure, as SMEs create these lists, the tie back to the persona and the clinical description and the parsing of what examples we're talking about is very important. We did that again very recently in GenomeX. We had an issue where, two of our reference labs that we are trying to harmonize for this used the same name but gave different definitions. I mean, so, it kind of, tells one that the mental model, if you just had an informatician going, oh, well, that's the same name, that's all right, that's good. I mean, if you just had that assumption, then we would have, severely misinterpreted it. So, having, someone who has got a SME mindset, to be able to read through this and give context to the examples is very relevant. So again, as I mentioned before, high level, but there's a lot of truth to this. Involve the SME early on in the process, and at least keep one throughout the whole process. So, even if they don't understand the nitty-gritty details of FHIR, I think a good facilitator will be able to, kind of provide the context and, in a way that can be best understood. Again, giving a really good shout out. Our facilitator in Genomics and is also a facilitator for CC Direct in some pieces. James Patterson, he's done an excellent job in a complicated domain like genomics to be able to disambiguate it with SMEs. And I would kind of call out that it would make sense to have a resource like that here too. Okay, I know we're really super, again, I can keep staying, we can keep talking about this, and we do want to talk about some mCARD situations. So quick pause, can I keep going, or do you want to?
Please don't let me distract you any further.
Oh yeah, no worries. I mean, this is all important. I just want to make sure that I'm addressing certain needs and keeping to some agenda. So
Yeah, nobody in the room's falling asleep, so.
okay. All right. So I want to talk, well, labs, I think we kind of talked about already, but I do want to point to something interesting in mCODE that I think may be a pattern you may find as well. And that's that labs are very difficult to comprehensively capture because there's so many various different levels of detail of what might be important. I'll give the high level thing first. First of all, how does mCODE treat labs in general? I think I already explained that, right? We don't limit ourselves to any labs, but by the same token, we also struggled with what were the relevant labs for cancer, right? It could be, I mean, if you have, it's true for cardiology, there's certain prognostic factors, you can run many different kinds of labs, right? Lab results, and some are chemistry, hematology, and, pathology. I mean, there could be many different areas. So what is a prognostic factor? And how would you distinguish it from other kinds of measurements, right? For the first one, say as an example, the one of highlight is two of them, tumor marker test, and the other one being genome, this whole green area of genomics, because one could think about this as a lab as well, right? Except it's a very complex lab, and the types of results that you get are, have various different formats like BCF or BED or BAM or something that's like truly deep in genomic data. How do we consider that, right? How did we separate out this notion of tumor marker tests and variant and external profiles? You're going to find that it's not that easy. And what did mCODE do? Well, first of all, we aligned with US Core because we're tied to it. So that's what you're seeing here. And then we also recognize, well, labs are being added every day. And what are the relevant ones? If we limited ourselves to just the ones we think should be there, then this might get old pretty fast, right? Because as you know, new tests get discovered, there's new LOIN codes that are being added. I don't recall how many, like if I had to have this diagram of how many new LOIN terms are added with every release, you're going to see that there's this exponential, I mean, this kind of exponential, growth of it. This is true for many other terms. So how do we keep track of that? Well, you're going to see that with mCODE, we kind of skirt that a little bit. And it says value, the code itself. We have a tumor marker test. Well, what kind of code is it? Well, we're going to give you some lists that we consider prognostic factors, and these are reviewed, right, by clinicians, which is fine. But we also know that we don't anticipate every clinician to know every test that a lab like Quest or LabCorp or BioReference will give you in return. And that is very much, an LIS, content kind of issue. There's no SME that can truly do all of that for you. And unless they work with all these labs and it every day. So how do we do this? We have a starter set, and then we have this binding that we call extensible. Now, some people don't like extensible bindings because they think at that point there are no guardrails, but it's a very pragmatic decision of when to be using something like extensible, which is we're going to almost, at least the way I see this, is that it should be kind of done in a way to also of new terms that we might be adding in a future release. Why? Because the notion of binding extensible means that if there is no applicable concept, which means that, whoever is doing the implementation is going to make sure that the labs that they have supported in their environment has some kind of coverage. If not, they're going to be adding it. But it is kind of, saying, hey, sender, do your due diligence to make sure that if you have a tumor marker test, it's one of these if it exists. We could not put the whole world around it. And I kind of think that might be the same, maybe it is, maybe it's not as extensive with cardiology, but I would not be surprised if you look at, all your test compendiums. Maybe one way you can do is you go to all, whoever is contributing, like Nebraska and whatnot, a couple of other sites, and you look at the test compendiums that you normally would have ordered in, for a cardiology workup for whatever, reason. And that could be your starter set, and then make the binding extensible. And as you do that, then I'd like to hope that within your community mCARD of implementers, that if they find that it is, if you have this data that you're able to look at, you could potentially match that code that they're sending you to the starter value set that you have. And then if it's not in there, then you can go, oh, well, this is a term we didn't think about before. And that is kind of in some ways a monitoring cycle that if you had a good terminology server, you're able to do. I know I did that a while back in a different company. We kind of did that as part of our ETL process. And the ETL engineer would come up to me because I was the content strategist / content manager, and they would do daily collections of data from several academic medical centers and over 100 community cancer centers, and they would say, oh, these following are not inside your value set, do you want to add them? And yeah, so then we ran a team that would literally add it to a part of the set and it would inform us. And I think that's an interesting cycle that is pragmatic. That's something that could be done once you have pilots. Okay, I know this is a weird one to go, but that's the way we kind of dealt with tumor marker test. Someone might say, well, then why do you have all this genomic stuff? It's because if, yes, it is a lab test. Yes, it mimics a lot of what's done with pathology, but the information that's sent back is not simply a small panel with things, analytes, and results. It is so much more metadata and extensive information around it that it basically became its own beast. And that's why it exists separate. But that's the way we kind of, in some respects, I would think it's the same way for yourself. If you have a very complex, cardiology, kind of, test that you feel is absolutely essential to be representing certain types of data for it, then you might want to go ahead and have dedicated profiles for that specific suite of tests, not necessarily just one test, but suite of tests. So, so that is kind of
setting line codes to for cardiac tests for a few decades.
yeah. Yeah, I mean, LOIC is definitely the way in some ways. Well, for genomics, I think that's a different scenario, but for hematology, for hematology and oh God, microbiology, a couple of other of the scenario chemistry. I think it fits nicely inside that kind of model that I just explained. And the one thing I would, oh, this is really getting a little wonky, but the one thing I would probably go towards is working, if you want to leverage the notion of a quote, it's not really ontology, it's more like this is getting really wonky, a multi-axial design of LOINC. So if I were to do, let's just do hemoglobin, right? So if I were to, although I'm sure there's a cardiac marker panel somewhere that we could look at as well. But if you see the way every LOIN code works, right, there are approximately 6 parts to behind every number that you see here. There are 6 parts that identify the property, the timing, which is case like a point in time, the system, or basically the specimen that is appropriate for it. It's a quantitative measurement, the class, and the method in which you're doing it. At this point, if you want to leverage, some kind of logic behind the scenes of, rather than go, here's our static value set, you could potentially do some kind of logic based on the properties in LOINC to figure out what are the sets of LOIN codes that are appropriate for your use case.
Right.
And in some way,
component and method a lot for doing that, say with blood pressure and echo imaging findings and so forth. So
yeah. Oh, we did it even more for mCODE. We use something called the part numbers. So we looked behind. So we went past this and we looked at, there's actually, like for genomics information, there is, I don't want to say, there is actually further parts that will say analyte gene, and it will split apart, the fact that this is a BRAF gene, and that's behind the scenes. So again, that's a more advanced concept as you create your own elements. This is way past the here's my initial elements. It's now getting more into the latter phases of the develop and represent the concepts. And it's very much an informatics exercise. But as you go through it, once you figure out the logic of how you did it, I would immediately go back and share that with a SME.
Right, and that Mike has made that more available lately on their site as well. So yeah, but that is getting down in the weeds probably.
Yeah, it's very weedy, but yes, but it's to say that I guess the takeaway here is that if you can have an open bundle, it's a little loose, but that's something, I guess, if you don't know how to narrowly scope your use case, that is one way that you can get around it. And using extensile as a binding can help to be suggestive of a starter set, but also allow for new terms to be used.
And so the place that we might have a common issue is the imaging findings, like CT scan findings versus echo or MRI and findings. There's a lot of stuff there that we'll need. Again, probably a distraction from this topic, but something that we'll want to be tackling, because finding is a core thing for us to classify our patients for decision support.
Yeah. Again, it really is getting wonky here, but to your point, you can leverage LOINC and panels, right?
We have in our EHR now in structured data, this particular panel, just because oncologists want it and cardiologists want the EF and the
Yep.
strength rate and some of those things.
Yeah, and you know, that's a really good, I know we're kind of a little bit off script, but this is a good thing. I mean, because again, we're totally over time, but I want to make sure this is helpful for you. But I agree with you. And if you know, with regards to this, I would say though that you know, if you're able to capture that, then fantastic. If you were going to, you know, work with a greater community that can only have certain pieces of it, then you know, I would agree that this might be one of them that has the most impact. So it depends on where you want to scope your phase, you know, your prioritization. I could easily see that this one is, you know, probably one of the most important ones that are actionable if you want to make the scope minimal and actionable, right?
So you've also published on how to extract that with NLP tools. So it's
yeah, that's true.
that's
That's
not-
another discussion for another day, but yeah. Yeah, I'm
sorry.
sure we've all had our own little playground in large language models and NLP tools using CLAMP or CTAKes or some of the other NLP tools for this. But yeah, I agree with you. Well, that's an interesting discussion for a different day for sure. So anyway, medications. I think this one, again, I'm not sure, you know, where you want to have this, you know, scope of it, but mCODE, it's interesting how we make it very minimal, right? We have this notion of medication requests, and maybe I'm going to get into a point where I'm not sure I always agree with some of these decisions that we've done, but it is what we have. Medication requests, again, because of our determination on US core, is for the most part kind of relegated to orders, right? And you know, the use case that drives it is, you know, what did they provide or order? And you'll see this is kind of nice because when you see in this, you know, example, you'll see that here are the examples in which we're using it, and they all kind of it's a provider-based order. Originally, mCODE had a statement as well, which allowed the notion of patient-stated adherence. So medication list, medication, you know, to support medication reconciliation, etc. That is not here anymore. In STU 2, because of limitations in FHIR. This is why you should always go back to your conceptual model, because you don't say, oh, it's because of FHIR, and then people don't remember why it's there in the first place. But if you see this, what we have done is not limit the value set of medications to just things that are oncology. Even though it says cancer-related medication requests, this is almost like the lab situation, except we go even further. We don't even give a value set for it, because we realize afterwards that if labs change often, you know, and need SME approval, and we don't have a steward that's constantly looking at this, medications are even more a challenge, because, you know, especially with targeted therapies, you know, oncology and medications are changing very quickly. They're adding, you know, more being added every day and so forth. And as a result, we don't really put any bindings onto medications to say use just this value set. We just say that if you're going to use it because of US core, use RX norm. So, and we make it extensible. And we did this because RX norm as a vocabulary does not include clinical trial drugs. They are, I think, FDA approved, you know, marketed drugs, and, you know, for oncology, and I'm sure for cardiology as well. You know, if you're thinking about clinical trials and you're thinking about new drug, you know, new drugs you're working with, then that's not going to fit. That's why we made it extensible. So then, if that's the case, then why call it cancer related? I mean, you know. Isn't it just regular medication requests? So what you're going to find at that point is that, well, we just basically add on top of it that the reason, one, you're going to go back to cancer patient, which if you look at cancer patient, all it really says is that it's any patient with a deceased, the possibility of populating deceased. It's not anything that's saying they are a cancer patient. It just says they're a patient. It happens to be an mCODE. This one, however, says that the reason, this is what makes it cancer related. It's because the reason that we're providing or ordering this medication is because of a cancer related condition.
So do you preserve dose anywhere in this?
Preserve dose?
Dosing, yeah.
Oh, yeah. So this is a differential table. I guess this is how you read this. A differential table is what are the customizations on top of US core, right, that we did, which is on top of the Firebase. The snapshot table, if you click on this, will give you all of the elements, including the ones that were derived, like your customizations and everything starting from the source of it, which is a base resource. And here is where you're going to find dose. So not only do you get dosage, you also get different forms of how you represent dose, which may be, specific, quantities as if in the form of a pill. And then you've got rates, right? Say in the case for infusions, and all the variations of how you can potentially represent dose.
Right.
But again, as you look at this, if you were going to draw a parallel for cardiology, you're kind of coming into the same quandary as I mentioned before. I mean, if you have a good scope where specifically either a knowledge base, maybe it could be a knowledge base where, someone is maintaining all of the cardiology related drugs and they're great stewards, constantly working every day. I mean, you have, I'm sorry, I'm just kind of OncoTree. Yeah. So I'm going to give an example, in research where they actually try and do this. Oh, it's not OncoTree, it's OncoKB, that's it. So OncoKB literally has people looking at this every day to maintain their oncology knowledge base, right? For this case, you might have an organization that does that, So if that's the case, then maybe you can further, constrain your list of, cardiac, related medications into one. But if you don't, then you're going to run into the same quandary that we're running into, right? What kind of stewardship are you going to have when there are drugs being introduced? And it's not even periodic. The way RX norm works is that, you've got weekly deltas, you got monthly deltas, and, and full changes. And sometimes they may happen somewhere in between, if if that kind of update changes often, then you may want to follow a pattern like this and kind of say, look, we're going to assume at this point that we're going to trust you, the sender, to tell us that the indication for this medication is for something that's cardiac related, and your reason code is now going to end up going to probably, your set of, cardiac related problems. Okay. And maybe that's a good first step, right? For you as you further kind of explore robust ontologies that allow you to, have more recent, data with, concept relationships and allow you to do like smarter searches for it. Okay. So that's that piece. I wanted to highlight this as well, that very much like the first level set of mCODE, there are patterns, and this is not called out in mCODE, this is called out in the US core medication requesting, for which mCODE, almost like what you said, e-consent, hey, we're going to refer to someone else. mCODE refers to US core to kind of call out, we're not going to tell you exactly one way that you're going to represent medications, but here's the pattern of how you can represent it. And this is something that you might want to think about as well. Again, you can accept this pattern, or if you have a small enough community, right, that's driving mCARD and you all agree that there really should be just one way of doing it, then further constrain your profile to take one of them. But there are, right now, like, pretty much call out 3 ways to do it. And I'll say, even from personal experience, I did experience this in a connectathon for DaVinci, where I did option 2, and 2 of the implementers accepting it did option 1. So, again, another value of why connectathons are so informative, and why, if you have a community that agrees to do it one way, just, get to that point if you can. If not, then call out the pattern. Okay. Oh shoot. Okay, I'll do one more, and then I don't know what I want to do afterwards. But to stop. But so cancer-related medication administration. I think there may be certain things that you might relate to here, but medication administration is usually scope for provider based, at least the way we were thinking about it in mCode, our examples show it that way, etc. The interesting thing, however, is that it's not covered by US core. Why, right? I mean, so again, it's not their scope. And what that does is go back to the heuristic that I kind of recommended earlier, which is, if there's 2 ways you can go about it. If you're doing your identification of elements that are important to you, and then at that point, everyone feels good about the definition, you have an informatician looking at it, it's like, well, there's nothing in US core for this. Let me fall back on the FHIR-based resource. And that is exactly what we ended up doing here. I mean, it's not shown in this picture, but if I had medication administration, there would be a line that goes directly up through this outside, right? It would be the FHIR-based medication administration, then we go up through here, right? That's one option. The other option is you can make the case for US core, which, again, I think is now highly informed by US CDI, and say, medication administration is important to us, right? And please add it. And it could very well be that US CDI, no, I think about it, let me see this. I think it is added at some point. Let me double check. But if that is, let's see, medications. I think it got added in like level 2. I did this recently. It got added at some point, I think. Yeah. Okay, so it got added at some point, although it's not in version 4. It's just in this level 1, and through the FDA. Maybe at some point it'll get there, but US core is more informed about the formal releases. So from their perspective, they're going to focus on this piece. If that's the case, then you probably want to be falling back onto the FHIR-based resource, and that's basically what mCode did. And then that's where you leverage the community afterwards and going, hey, this might be important to us. US core, when you're ready, please add it. You work with that, team in order to get that through. And then it'll be there, but don't, again, that's why go back to your concept model, because it'll give you certain decisions were made and why you ended up pulling from a base resource as opposed to the, the dependency for United States, or in your case, IPS. So, okay, I'm going to pause with 5 minutes. Before the top of the hour. Another quick check. Is this helpful? Is there, major things that you would like to go over?
Yes, that has been helpful. First, it'd be interesting to get a hold of your draw.io for the main example file there, just so we can play with how that works. I've tended to like using some of those. I've used the various versions of that. Second is there anybody like in Europe that has tried to take some of this stuff and plug in, say, like ATC codes for drugs? Because there's some interest in that. I think most of the stuff is going to work across the pond. I know there's some significant differences in Australia with medication approaches, but interest in working that out. So have you done anything like that? Have a European group or somebody play with some extensions for something like med administration or something else? Because I think it's doable. It's just a matter of thinking it through, which is another advantage of sort of starting global, and most of it's going to line up, but some occasional compromises are needed.
Yeah, I think you're right. So, I mean, from the mCODE perspective, not to the level of detail that you talked about. Again, we mCODE is very driven by US-centric, a US-centric community, although that is now changing because we have like Oncoclínicas from Brazil that implemented aspects of mCODE, and we had, we have others that have had of interest too. I think, I think it's in place in the Netherlands, but to that level of detail of medication administration in particular, we've not really had that discussion. But I could see what you're talking about, though. So if we were to really bring something like this up, I don't know how active you are in the pharmacy working group at HL7, but I'm sure that would be useful there. And then, of course, obviously the group that's working on IPS. I forgot who the steward is. There's a working group behind IPS. Hold on, let me see if I can find it. It's usually at the top.
Yeah, didn't want to derail things.
Patient care.
Yeah.
Yeah,
Very
surgeon.
We just need to work through some examples to get started.
Yeah. Oh, did you? I mean, so when you? Yeah, I see what you mean. If you can further, like, kind of scope, right? Again, it seems like a very broad question of, hey, have you used ATC? It's like, yeah, I've used ATC. I'll tell you what I would end up doing with it. I mean, there's two options. You can, from medications, medication requests, you can actually have a link to medication knowledge, and that medication knowledge for that, medication could be, the drug class, right? I mean, that's, there's ways that you can go around it, different patterns, but yeah, until you have a community that further scopes what you want to do with it, I think that's, I think it's a little bit of too broad a question. So if you can further provide for me a bit more context of how you want to use it afterwards, that would be helpful.
I'd also
Still have to figure it out.
Yeah.
It's probably a much deeper rabbit hole than you want to go down, but FDA and WHO and EMA have been working on IDMP. They have a work group together. They've been working on some standards. I can help connect you to the folks at FDA who work on that.
Yeah.
But that may be a longer term project.
That's not feasible for us, but,
No.
but it's important.
Yeah, I mean, I feel like in my experience, the biggest problem with ATC codes there's a lot of unmapped due to different approval for
So
our
let them fix it.
Yeah, and I don't.
Let's
Yeah, no, this,
like that to work because their installations are in Indonesia and in actually in Dubai.
yeah. I don't know if you've.
So maybe we are at the top of the hour, and my understanding is that you probably had to go.
I do.
This has just been absolutely terrific. We've got much more than we can quickly comprehend, but it's clearly what we need to get going. So just wanted to thank you for your time and your effort. This is the beginning of a discussion, And we'll be calling on you if you don't mind quite frequently here.